and today's presentation is on palliative care, and the title of the talk is Achieving the Best Quality of Life While Living with a Chronic Illness. Sure. Can you hear me now? Not great? Maybe we should ask the sound person.
You should be able to turn it up here. Yours here.
Oh, there we go. Let's try again. So welcome to the St. Paul's Hospital Own Your Own Health Community Forum, and today's presentation is on palliative care, achieving the best quality of life while living with a chronic illness. And I'm Gil Kimmel. I'm a doctor in the palliative care division as well, and my area of interest is really in heart failure supportive care, and so we're really excited about the talk tonight. Now this session happens every third Wednesday of the month, and it gives us a chance to highlight important health topics and innovation in research and education that we're doing at Providence Healthcare. And tonight, like the other sessions, there's an opportunity at the end to ask questions. So please write down your questions and give them to Mani, who is not here at the moment, but she will be here, and we will answer the questions as best as we can. Now, unfortunately, there isn't a presentation in October. However, there is one in November, and it's going to be on November 21st. And Dr. Amanda Hill, who is the acting head of the Division of Geriatric Medicine, will be presenting on dementia. And Dr. Hill is an outstanding clinician and teacher. She was one of my teachers, and I think it'll be a great presentation. And tonight, we're very pleased to have Dr. Romayne Gallagher, who's the head of the Division of Palliative Care. And she's a family doctor with a lot of experience in palliative care. And she's also the physician program director for the palliative care program at Providence Healthcare. And she was the founding director of the Division of Palliative Care at the University of British Columbia from 1997 till 2003. And while she was there, she helped establish the undergraduate, postgraduate, and interprofessional teaching in palliative care. Dr. Gallagher is also a clinical professor in the Division of Palliative Care at UBC. She has published research articles and authored chapters in palliative care and pain management. She was co-chair of the Public Information and Awareness Working Group of the National Strategy on Palliative Care and End of Life that ended in 2007. She's worked as a consultant for Pallium, a federally funded initiative to improve palliative care education. And lastly, she has helped establish the BC Palliative Care Benefits Program, which funds medications and supplies for those wishing to be at home near the end of their life. So welcome, Dr. Gallagher.
Thank you very much, Gil. Can everybody hear me? Yeah, you're okay? A little louder. I'd be happy to speak louder. That's no problem. Probably if I just tilt my head down a little bit. Thank you very much, Gil. It's a pleasure for me to talk tonight, and I really appreciate all of you being here. And I also want to very much welcome one of the nurses on our team, Pat Richardson, and whose nurses are very much a part of our team in all that we do. I think the best way to give you a window into why palliative care developed is to go back through the history of medicine a little bit. And our earliest concepts of the cause of disease were that it was an intrusion of evil spirits. And we used to treat disease by providing an exit for the evil spirits. If you look at this interesting skull picture, you see 3 holes, which were likely the cause of death. This was likely a crude treatment that was used to treat headaches, and this would be one way of letting out the evil spirits. You can see faintly, if you look to the right of the holes, as sort of a concave area of the skull where likely this person had a previous treatment and recovered from it. In general, at this time, death was a very short event that would only last a matter of days, and it was usually due to an infection. In this case, this would have been an infection secondary to making these holes in the skull. The Egyptians thought that the spirits of the dead entered the body at night and caused disease, and the spirits could be brought out of the body through vomit, urine, and sneezing. And so many of the treatments were aimed at causing vomiting, sneezing, or urinating to occur. They also thought that the heart was the center of sensation and not the brain. Egyptian therapies at that time did focus on inducing vomiting, sweating, and sneezing, but there also was the first prescription for the use of opium for headaches. And we actually have a long history of use of opium or morphine-like drugs to treat pain and shortness of breath and other symptoms, period. Chinese techniques in early times involved diet, exercise, pressure, heat or cold, and acupuncture and moxibustion, which is a kind of cupping treatment to draw the circulation, draw more circulation into various parts of the body. And these treatments are still used today. The ancient Greeks, from which Western medicine comes, felt that disease was caused by an imbalance of 4 bodily humors, and they were called blood, phlegm, yellow bile, and black bile. And if there was an imbalance causing disease, the way you could restore health was by trying to rebalance these humors. So if it was the blood humor that was out of balance, you would bleed the person, or if it was various phlegm, you would cause coughing, etc., and purging to deal with other humors, period. This obviously was very difficult on people and oftentimes didn't really result in much effect. In fact, the average lifespan at this time was probably somewhere around 20 to 33 years of age, not because everyone died at that young age, but because so many people died in childhood from infectious diseases, and so that's why the average rate is so low. Throughout the Middle Ages in Western society, there was a period of what I would call darkness after the fall of the Roman Empire. Knowledge pretty much was confined to monasteries, and there wasn't much advance in medical knowledge. Part of the problem is that dissection of bodies had been prohibited in Western traditions, so nobody really explored some of what bodies looked like after they had an illness. The other thing that took a devastating toll on Western society was the plagues of the 1300s and 1400s, which killed about a quarter of the population of Europe. However, in Arabian societies, medicine continued to advance, and at about 1000 AD, there was the canon of medicine, which prescribed opium, herbs, cold heat massage, and other therapies to treat disease. The first big changes in Western medicine came with the Renaissance, where people began to dissect bodies again, and there began to be a more scientific inquiry into the cause of disease. So doctors began to notice that when people died, there were dramatic changes in their organs, and they began to associate the changes in the organs with the symptoms that people experienced. And this made a dramatic difference because they started to connect the dots on what was going on. However, what was done in universities and medical schools of the time was not necessarily practiced in the community, and there's some interesting and sort of comical things that were recommended throughout this time. People were keen to try and prevent or resuscitate people and prevent them from dying when they stopped breathing. And in fact, a bellows method of trying to breathe air back into people was tried around the 1500s. Even in 1767, trying to resuscitate someone from drowning, they were recommending these very strange things like insufflation of smoke of burning tobacco into the rectum. So you could see that there was various levels of advancement in medicine. And even very strange techniques such as hanging people upside down and rolling them over barrels to try and resuscitate them. One wonders if the expression over a barrel didn't come from this very procedure. Medicine before the 17th century was very different from what we have now. There was no diagnostic technology, no tests. Physicians did not really do physical exam. Diagnosis was based on the senses, sight, touch of the wrist to feel the pulse, hearing, smell, and taste. And the way diabetes was diagnosed at this time was by the physician tasting the sweetness of excess sugar coming out in the urine. The same therapies were still used at this time: bleeding, sweating, purging, vomiting, urinating. Surgery was the last resort, and there was no anesthetic. The use of opium, however, was still a very effective medicine, and it was often called the gentle medicine because it wasn't like purging and vomiting and other therapies. It was known to relieve the effect of fever, it was known to relieve pain, to reduce diarrhea, to protect against shock, to reduce cough and shortness of breath, to help people sleep better and reduce the effects of anxiety and stress. And a famous physician in the 1600s, Dr. Thomas Sydenham, in this quote here said that opium was a wonderful treatment and it was universal and efficacious. Medicine in the 17th and 18th century began to make some progress. For example, one of the major discoveries was that in fact the heart was just a pump and wasn't the center of sensation and thought. And this was figured out by Dr. John Harvey. And at this time, the microscope was invented, and this allowed people at the first time to see bacteria and other causes of disease. Around this time, people began to notice that the use of carbolic acid and cleanliness reduced infections after surgery and reduced the number of women dying with what was called childbirth fever, which was an infection after birth. In the 1800s, there were some dramatic changes. For one thing, we were finally able to isolate the active ingredients in opium, and that's how morphine was discovered in 1806 and codeine discovered in 1832. In the mid-1800s, the syringe and needle was introduced, and now one could precisely deliver an exact amount of pain medication. Before, it was pretty much a oral treatment given by mouth and no other way. An amazing change came about in 1846 with the beginning of the use of ether for surgery. Local anesthetics like cocaine was discovered in 1884, and of course aspirin discovered just at the turn of the century. In the 20th century, there has been incredible changes in medicine, although I must say at the beginning of the 20th century, the average lifespan was still in the 40s. In other words, many people still died in early childhood and at childbirth from infections and so on. And in fact, what had made the most difference at this point was actually nothing in medicine. What had made the most difference was separating drinking water from sewage and city planning that began to move people apart so they didn't live on top of each other. And these changes accounted for much of the improvement in the lifespan. In the 20th century, there was the discovery of radiation and X-rays that allowed us to see inside the body. The ECG was developed in 1912, and the first development of antibiotics to cure infection. In fact, many of our treatments in the 20th century came as a result of war, unfortunately. And the beginning of cardiac resuscitation was in 1960. Here's a picture of the first ECG machine. You can imagine the incredible changes that have allowed it to be made into a tiny little cart that can be wheeled around and give a digital outprint as it does now. The amazing changes that were occurring in medicine affected the way we looked at medicine. There was indeed the rise of a scientific method, so a rational approach, which said the cause of all symptoms can be found in the pathology at the tissue level. But what this did is doctors began to see symptoms only as clues to the diagnosis, and they often ignored those symptoms because they were looking to the diseased organ or the diseased tissue to find out how to cure it. A high value was placed on measurable data and tests, and medicine's chief goal, you could say, became curing and preventing death. And this is a 1920s picture that shows the title underneath it is "Physician Struggling with Death for Life." And you can see that the main battle here is between the physician and death, as represented by the skeleton. And the patient who is caught in between this struggle is faceless. And, you know, I think this is very interesting that the patient has almost been lost in the struggle here between the physician and death. With these dramatic changes in medicine, people lived longer, but they also took longer to die. So instead of dying of infectious diseases that would take one in a fairly short period of time, people would survive these, but would grow older and accumulate many more chronic illnesses like cancer and dementia and so on. People began to die with pain and other symptoms that were being ignored. And people at that time were not told that they were dying. This is where palliative care began to evolve from. And it began in England, and the prime person credited with establishing this treatment was Dame Cicely Saunders, who founded St. Christopher's Hospice in 1967. Dr. Saunders started out as a social worker, then became a nurse, then a physician. And she made dramatic changes in how we began to look at the way we treated disease. And this made a lot of sense to people. And our first palliative care unit in Canada opened in 1974. In 1980, the Vancouver General Hospital opened their palliative care unit. And in 1989, St. Paul's opened their palliative care unit. Initially, palliative care was only for those with a terminal illness who were clearly dying. Most of the time, these people had cancer, the vast majority of time, in fact. The focus was on controlling symptoms, treating the whole person, body, mind, and spirit, supporting the family, and supporting survivors after the death. Now, I'd like you to look at the World Health Organization most recent definition of palliative care, and this is from 2005. And it says here, palliative care is an approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification, impeccable assessment and treatment of pain, and other problems, physical, psychosocial, and spiritual. So as you can see, palliative care is now considered an approach to care, and it's backed up by medical evidence, which I'm going to show you. We still do focus on controlling symptoms, but more than just controlling them, we also wish to try and prevent and relieve suffering. And as you can imagine, people understanding what's going on and what to expect in the future will suffer less from being frightened about what's going to happen. Thinking ahead, trying to prevent suffering is a lot of the way that we try and work and prevent suffering from symptoms and complications. We also focus again on treating the whole person, body, mind, and spirit, but we try to identify people much earlier in their illness who would benefit from palliative care. We consider that palliative care can benefit any life-threatening illness and at any age. So it's not just cancer, it's not just adults, it's across the lifespan and any disease. And of course, we support the family and support survivors after the death. People often find it very confusing to understand the difference between the terms that are used. So what's the difference between palliative care and end-of-life care and terminal care? And if you look at this diagram, which our team developed, I think it helps explain it a little bit better. You can see that palliative care encompasses the whole thing, including an introduction to palliative care, symptom management, maximizing quality of life, and for anyone living with a life-limiting illness. So in other words, any prognosis, you could have years to live and still benefit from palliative care. Within that, we call end-of-life care the last weeks to months of life. So when it becomes obvious that people are nearing the end of their life, we call this end-of-life care. And this is still, we might have disease-modifying treatment going on, and people may go to hospice at this time. And hospice is actually not a specific treatment, but focuses on a place where we provide end-of-life care. And then the smallest part of what we do, terminal care, focuses on the last days to hours of life, when we focus on keeping symptoms under control and supporting the patient and family in this transition. What do patients, I should maybe not use the word want, but what do they need when they have a life-threatening illness? And people pretty much say they need pain and symptom control, and I think most of us would agree with that. They also want to avoid inappropriate prolongation of the dying process. So in other words, when it becomes obvious that that it's their time to go, they don't want to prolong that process. They want to achieve a sense of control. This might be even control over the symptoms, control by knowing what's going on and what's happening and being involved in planning care. They want to relieve burdens on family. They don't want people to be exhausted looking after them. And importantly, they want to continue to grow as a person and to strengthen relationships with loved ones, so that we see that people, even at the end of their life, are still very much living and growing. What do family caregivers want? This study is based on a study of 475 family members, and it is 1 to 2 years after the death, but people's memories last for a long time. And you'll notice here that as well as honoring loved ones' wishes and preferences and being included in decision making, people also found that as a caregiver, they needed lots of practical help. So help with medicines, equipment, transportation, personal care, and they also needed the availability of someone they could call when they got frightened because they didn't know what to do. And of course, honest information about what's happening, and particularly to be remembered and contacted after the death in order to help them grieve and understand what happened to their loved one. So I want to show you some of the very interesting data that we have now that shows that palliative care is helpful and effective. And in hospitals, we know that compared with usual care, palliative care teams showed significant improvements in pain and other symptoms, patient and family satisfaction, hospital length of stay, and reducing deaths in the hospital. And most people do not wish to die in hospital. In fact, we know that 50% of people prefer to die at home, and around 50% of people prefer to die in a facility, but more likely hospice or another place aside from the hospital. We know that people need to have enough time to access palliative care in order to benefit from it. And we know, for example, these statistics that I'm showing here are taken from US data, but they are similar to some of the data that we see in Canada. And there, people have an average length of stay involved in hospice programming of 22 days. And 35% of hospice patients only receive care for less than 1 week before death. And the median stay in hospital before even being referred to palliative care is 18 days. So oftentimes people are saying to us, we wish we had have seen you before. We do know that from a study that late referral to palliative care results in family members saying that family members having lower satisfaction with care, more unmet needs, lower confidence in the care they're receiving, and more concerns about coordination of care. So how does palliative care help reduce the length of stay in the hospital and the cost? Well, palliative care works with the patient and family to clarify the goals of care. We help families to select medical treatments and care settings that meet their goals. And we assist with decisions to either leave the hospital or to withhold or withdraw life-prolonging treatments that don't help to meet their goals. And I want to show you some statistics just so that you can see it in a graph form. If 0 is the day that the person actually has a consult with a palliative care team, you can see that their costs do drop dramatically, even if they have a longer length of stay in the hospital. But the most exciting news that I want to share with you tonight is a very well done study that was first published in 2010. And this was a study that took 151 patients who were newly diagnosed with metastatic lung cancer, and they were randomly assigned to early palliative care versus usual care. And what they looked at the end of the study was how long did people live, what was their quality of life, and what was their mood. The two groups, those who had early palliative care and those who had usual care, still had the same amount of chemotherapy. However, they found that the early palliative care group had a much better quality of life, a significantly better quality of life, and fewer depressive symptoms. The interesting thing was that those people with early palliative care lived 2.7 months longer than those who had usual care. And that surprised a lot of people. And it's wonderful to see this as evidence because many of us who work in palliative care have seen many people get better and do much better than expected when their symptoms are controlled and their anxieties and concerns about the future are dealt with. So those of us in palliative care tend to see that palliative care can be introduced at the diagnosis of an illness, and in fact goes hand in hand and is completely appropriate and can be integrated with disease-modifying or disease-controlling therapy, that there is no need to choose between controlling the disease or having palliative care, that the two can exist side by side and improve outcomes of illness such as quality of life, mood, and length of life as well. And I want to give you an example of how this might work for an individual patient. And I'm considering a Mr. and Mrs. C. Mr. C has chronic obstructive lung disease, and he may have been receiving disease for some time, but he still could know that when needed, he can benefit from palliative care. And the first time he might benefit from palliative care is being in hospital with a pneumonia, and obviously getting the pneumonia treated, but perhaps introduced to the palliative care team at that time for discussion about what decisions might have to be made at some point in the future. And in fact, Mr. C, at some point, may decide that he does not wish to go to ICU or be on machines. He may or may not decide that, but that would be a way in which palliative care could help. The third star along from left to right, he might be in hospital again for a pneumonia and begin to have some bad shortness of breath, which could be treated with opioid or morphine-like medications to assist the shortness of breath. And he may find that as his disease becomes more advanced, that all the puffers and other medications don't really help him to be less short of breath, and that in fact opioids on a regular basis for shortness of breath help him to keep him functioning as best he can. And then as Mr. C's illness progresses and he gets into the final months, Mr. C might go into a hospice. And then after Mr. C dies, Mrs. C might attend a support group to help her deal with grief and deal with any unanswered questions about her husband's illness and so on. So that's an example of how we can help individual patients. You know, it doesn't take a special team to do this, because the kind of things I've talked about, right? Listening to the person, trying to control their symptoms, supporting their family, thinking about them as an individual rather than a heart or a kidney or a cancer, that's just good health care, right? And so if we can start to build that kind of capacity or ability in chronic disease management teams, then they can do much of that care as part of your chronic disease management. And I think that's what Gil was trying to say, is that palliative care is going to become a more and more important part of chronic disease management. So that's our hope. But as always, it's a bit of a struggle to get the decision makers to change the system around a little bit to focus on this care, right? That's going to take time and evidence.
Okay. So this is a fantastic question, whoever wrote this. This is really important to our team. And I'll read it out loud. So hospices are overflowing now. Is there any funding and a plan to expand? So yes, I agree. Hospices are definitely overflowing, and sometimes we're even faced with the situation where the palliative care unit and the medicine wards have patients that remain in hospital en route to hospice because they're full. And so, I think I would speak for the organization of Providence in saying that yes, we are very committed to expanding the hospice beds for patients in the Lower Mainland, and that is really one of our priorities because we believe as a group that hospice care is really paramount to management as patients near the end of life. Anybody else want to add anything?